Anticoagulant medications are used to prevent blood clots from forming. These medications work by interfering with the normal function of plasma proteins called coagulation factors, which take part in secondary hemostasis. But let's focus specifically on the anticoagulant warfarin, which works by preventing the synthesis of coagulation factors 2, 7, 9, and 10. Now, to understand the regulation of clot formation, we first need to talk briefly about hemostasis, in which hemo refers to the blood and stasis means to halt or stop. Hemostasis is divided into two phases, primary and secondary hemostasis. Primary hemostasis involves the formation of a platelet plug around the site of an injured blood vessel, and secondary hemostasis reinforces that platelet plug with the creation of a protein mesh called fibrin. To get to fibrin, a set of coagulation factors, each of which are enzymes, need to be activated. These enzymes are activated via a process called proteolysis, which is where a portion of the protein is clipped off. In total, there are 12 coagulation factors numbered factors 1 to 12, but there's no factor 6. Most of these factors are produced by liver cells, and it turns out that producing coagulation factors 2, 7, 9, and 10 requires an enzyme that uses vitamin K. Now, when vitamin K is mobilized from fat cells or the digestive tract to the liver, it's in its dietary form, and it's called vitamin K quinone. An enzyme called quinone reductase takes electrons from NADPH and donates them to vitamin K quinone, converting it into the reduced form, which is called vitamin K hydroquinone. Then, vitamin K hydroquinone acts as a cofactor by donating its electrons to an enzyme called gamma-glutamyl carboxylase, which converts the non-functional forms of coagulation factors 2, 7, 9, and 10 into their functional forms. Gamma-glutamyl carboxylase adds a carboxyl group, which is a chemical group made up of one carbon and two oxygens, onto the end of glutamic acid residues on the proteins. After the carboxylation step, vitamin K is in an oxidized form where it can accept electrons, and it's called vitamin K epoxide. Vitamin K epoxide gets converted back into vitamin K quinone by another enzyme called epoxide reductase, which donates electrons to vitamin K epoxide using a thiol group. In this fashion, a single molecule of vitamin K can be reused many times. As it turns out, the drug warfarin, which was first used as a rat poison, blocks the function of this enzyme, which blocks vitamin K from getting recycled, and as a result, factors 2, 7, 9, and 10 don't get activated. Now, let's take a closer look at the coagulation cascade to see where these coagulation factors play their respective roles. The coagulation cascade begins via two pathways, the extrinsic and intrinsic pathways. The intrinsic pathway starts when circulating factor 12 comes into contact with the surface of activated platelets or collagen. Activated factor 12 then activates factor 11, which activates factor 9, which activates factor 10. Factor 10 starts the common pathway where it activates factor 2, which activates factor 1 that builds the fibrin mesh. When factor 2 gets activated, it also activates 4 other factors: 5, 8, 9, and 13. Factor 5 gets activated and acts as a cofactor for 10. Factor 8 acts as a cofactor for factor 9, and factor 13 helps factor 1, or fibrin, form crosslinks. In the extrinsic pathway, exposed tissue factor activates factor 7, which activates factor 10 and starts the common pathway. So, without vitamin K, the loss of factor 7 means that the extrinsic pathway won't function. And without factor 9, the intrinsic pathway won't function. And without factor 10 and 2, the common pathway won't function. Warfarin is taken per oral, and it affects the extrinsic pathway first, since factor 7 has the shortest half-life, and it's the first coagulation factor to run out. Next, levels of factor 2, 9, and 10 also drop, causing inhibition of the intrinsic and common pathways. Since factor 7 drops first, warfarin's efficacy is monitored using a blood test called prothrombin time, or PT, which is a measure of how well the extrinsic and common pathways are functioning. To perform this test, blood is drawn and the plasma is separated out by centrifuge. The plasma contains all the coagulation factors minus tissue factor, which is normally found within the blood vessel walls. Next, tissue factor is added to the plasma to trigger coagulation, and the time until the sample clots is measured. This measurement is called the prothrombin time, also abbreviated as PT, and it's compared to the control PT, which is the time it takes for the blood to clot in a healthy person. Now, the problem with PT is that there are multiple testing kits from different companies, and they all cause clotting at different rates. So, it's helpful to convert the PT into a standardized value called the INR, or International Normalized Ratio. This can be done by dividing our patient's PT by the control PT provided by the company. For example, if the person's PT is 22 seconds and the control PT is 11 seconds, their INR is 22 over 11, or 2. This means that that person's blood takes twice as long to clot compared to a healthy person. A normal INR is 1.1 or less, but for someone taking warfarin, the goal is to achieve an INR between 2 and 3. The main use for warfarin is in the prevention of disorders caused by blood clots. These include deep vein thrombosis, or DVTs, which is when venous blood clots called thrombi form in the deep veins of the legs. These thrombi can cause pulmonary embolism when they travel to the lungs and block off arteries. In people with arrhythmias, or particular atrial fibrillation, the blood could pool in the heart, leading to blood clot formation. These clots then get pumped out of the heart and make their way to the brain, where they block off cerebral arteries and cause strokes. Other common causes of blood clot formation in the heart include prosthetic heart valves and recent myocardial infarctions. Warfarin is the medication of choice for preventing these problems because it's taken peroral, so it's very convenient. It also has a very long half-life of around 40 hours, so it can stay effective for 2 to 5 days once therapeutic levels are achieved. In terms of toxicity, the most common problem with warfarin is uncontrollable bleeding, most commonly in the GI tract when the INR is higher than 3. This can result when the dosage is too high, or other medications can prevent warfarin from being metabolized. Normally, warfarin is broken down in the liver by a class of enzymes called CYP450 oxidase. Certain common medications like cimetidine, omeprazole, metronidazole, trimethoprim sulfamethoxazole, and amiodarone can inhibit this enzyme and cause warfarin to accumulate, thus increasing the INR. On the other hand, some medications like griseofulvin, barbiturates, phenytoin, and carbamazepine can enhance the activity of CYP450, which speeds up the metabolism of warfarin, and we get a subtherapeutic INR that's under 2. Therefore, it's extremely important to find out what medications a person is taking before initiating warfarin therapy. Next, warfarin can cross the placenta and cause congenital heart defects and brain malformation in the fetus, so it's contraindicated for pregnancy. Another problem is warfarin-induced skin necrosis, which is caused by tiny thrombi forming in the blood vessels in the skin. This happens because warfarin also inhibits the synthesis of the functional form of a vitamin K-dependent anticoagulation protein called protein C. Normally, protein C combines with protein S to form a proteolytic complex, which inactivates activated factor V and factor VII. Now, protein C has an even lower half-life than factor VII, so they are the first to disappear when someone takes warfarin, and hypercoagulation happens before the anticoagulation. To combat this, another anticoagulant called heparin is often given at the start of warfarin therapy. Heparin enhances the activity of another anticoagulation protein found in the body called antithrombin 3, which normally inactivates activated factor 2, or thrombin, and factor 10. This balances things out until the anticoagulative effects of warfarin kick in and we can stop giving heparin. If a person suffers from severe warfarin overdose, obviously the first step is that warfarin should be stopped and a prothrombin complex concentrate, along with vitamin K, should be given. If there's active bleeding, fresh frozen plasma, or FFP, should be given since it contains the functional forms of coagulation factors 2, 7, 9, and 10. Alright, as a quick recap. Warfarin is an anticoagulant that works by inhibiting vitamin K epoxide reductase for factors 2, 7, 9, 10, protein C, and protein S. It is administered orally as a long-term anticoagulation strategy to prevent clot formation. Its toxicity profile includes bleeding, medication interactions, teratogenicity, and skin necrosis due to its ability to transiently lower protein C levels in the blood.